Welcome to Health Options. Health Options is the program that not only tracks government policies on health, but helps you with the right information you need to make informed choices about your health. Thanks for joining us on the program. I am Rabi Abdullah. Universal health coverage is about ensuring all people and communities have access to quality health services where and when they need them without suffering financial hardship. Financial protection through public or private health insurance substantially reduces the amount that people pay directly for medical care. Yet, in some countries, the burden of the out-of-pocket spending can still create a barrier to healthcare access and use. Households that have difficulties paying medical bills may delay or forgo needed health care. Nigeria's out-of-pocket expenditure as a share of current health expenditure was 76.6% in 2018 and down to 77.2% in previous years. Universal healthcare means there is a healthcare system that prompts coverage to at least 90% of citizens. On this episode of Health Options, we beam our searchlight on Nigeria's efforts at achieving universal health coverage for its teeming populace, with the Executive Secretary, National Health Insurance Scheme, Professor Mohammed Nasir Sambo, as my guest. If you're just joining us, this is Health Options, and we're taking a look at Nigeria's efforts at achieving universal health coverage. And with me in the studio is the Executive Secretary of the National Health Insurance Scheme, Professor Mohammed Nasir Sambo. Thanks for coming on Health Options, Prof.
Thank you very much, Madam, for inviting me to this occasion.
Okay, the last time you were here, we discussed extensively, and we really like to know what had happened after that, because there were so many initiatives that you highlighted on the program then.
Yes.
It's all about making sure that the citizens get to spend on healthcare without thinking about the size of their pocket. How far have we gone from the last time?
What we have done were well known. Issue that has to do with, for the first time, NHS was trying to develop the 10-year strategic plan, which has been completed, which is now being implemented. Issue that has to do with our effort to embark on comprehensive digital transformation, whereby NHS business process will be fully automated. And I think in the last interview we made a mention that we have gotten Federal Executive Council to automate our business process, and that has been concluded. The infrastructure has been fully developed now and is about to be launched. This represents the third phase of our effort to digitalize the system. The next phase is to ensure that there is what we call interoperability,
okay,
where you have a connection between the National Health Insurance Scheme and all the stakeholders.
I started from where I started because I'm aware of the low ebb where, for instance, in my intro, 76.6 in 2018. You highlighted a whole lot of initiatives that were going to be put in place to boost coverage. And I'm aware of the coding system, the issue of introducing medical doctors and all of that. And we know that those are existing practice, just like you mentioned. Bring us up to date, what difference that had made. Because at the mention of, health insurance or universal health coverage, we're looking at, the things I had to spend money on healthcare, if I had to access, I am spending less on that now. Is that the picture?
Yes, absolutely. You see, it's not, when you are talking about universal health coverage, you are not talking about one component. You are talking about three components, basically three components. There is what is called population coverage. One of the elements. Number two, service coverage. Number 3, talking about cost coverage. And it is important to understand that it's not one agency that is working towards attainment of universal health coverage.
Can we limit it to your own component?
Yes, our own component is a supply side, is a demand side. Okay. National Health Insurance Scheme and health insurance at subnational agencies are responsible for strategic purchasing. Strategic purchasing in the sense that how do you aggregate funds to purchase services on behalf of the people that are paying. So if you want to really know what we have done, progress from our last interview, you know that I told you that we have developed a gift ship program, which is a group which is called Group Individual Family Social Health Insurance program that will bring informal sector, which hitherto are not part of the arrangement of the National Health Insurance Scheme. So that program has been developed, and in fact it has been developed further to have different variants.
Is it operational?
It's operational.
It's operational.
Yes, so we have what we call gift ship for general population. We have gift ship for retirees population. We have gift ship for NYSC. We have just launched NYSC program, which is bringing about 360 youth corps members every year into the National Health Insurance Scheme. We thank Mr. President, President Muhammadu Buhari for not only approving the program for the NYSC people, but for even causing the release of the fund. So part of our achievement from what we have done. And secondly, if you go to every state now, if you go to our MCC, you will see per second the number of people that are coming to enroll into the gift ship program. So, and if you also look at what we have done in the Basic Healthcare Provision Fund, as of the last interview, we say that states have created their agencies. Now they are moving into enrollment, and people have started receiving care. If you have observed what is the trend of what happenings in the National Health Insurance Scheme in the last few months and weeks, is that of moving from one state to another to launch the program at the state level. Just last 2 weeks, we have launched the program in Abuja for Ogun State. We have launched, a week before then, we have launched a program in Adamawa. This is a component of the federal government support for expanding care through the Basic Healthcare Provision Fund. We have discussed what is Basic Healthcare Provision Fund. It's a program whereby 1% of the total consolidated revenue of the federal government is coming into the health system. Half of that money is coming to the National Health Insurance Scheme. National Health Insurance Scheme is remitting that money to the state health insurance agencies, who are in turn enrolling people and giving them access to care. You know, sometimes you, the media, you want absolute number. We are more concerned about putting structure that will bring the absolute number, which is more difficult, because when the structures are there, the numbers will just be coming, just like we have the gift ship program.
Yeah, but I thought with monitoring and evaluation, comes data. So yes, if you have that.
Yes, like I said, the people are coming day in, day out. If I even give you data now, if I go out of this place, they will tell me that there has been increase. Okay. So just appreciate that structures are being put in place, and people are getting confidence that NHIS is reforming, and people are coming.
Okay. Yeah. What I wonder with gift ship means that be it informal or formal sector, more people can come.
Absolutely.
How aware are people out there? Because I know with the formal sector, an enrollee has his 4 dependents.
Yes.
That is, accessing services. One becomes maybe 18. He exits.
Absolutely.
At that point, he could either be going to the university or doing some other thing.
Yes, yes.
On the other hand, a civil servant who had maybe put in 35 years in service or had clocked 60 is exiting. How aware are they that they could still be, enjoying healthcare services without really, thinking about the financial burden.
Yeah.
What sort of platform do you have that creates that awareness, that has sensitized people in that regard?
Yes, sir. This kind of program cannot be consumed without creating information, without education, without communication. Mm-hmm. And part of what we are doing here is part of what we are doing to inform and educate and communicate to Nigerians that such programs exist for not only the formal sector, but for people that have ability to pay. And this kind of forum is a forum that you will tell people that there is a program of the federal government of Nigeria that is driven by the state. And apart from this sporadic meeting interview that we have, if you go to the National Health Insurance Scheme, you now see that we have a very comprehensive weekly program that we drive in the NTA station, and we have also radio station, and it's being rolled in different languages. And I know that we have we at the level of FRCN we have worked and we have developed a communication strategy to reach out to people in 4 critical languages. So we are promoting most of the program that we are doing, and at our state level. Part of what we say we will do, we are to strengthen the state offices to be able to perform a deeper stewardship function in terms of marketing the giftship program, meeting the traditional rulers, meeting the philanthropists, meeting people that can come into the giftship program. So all these things all these strategies are going on at the same time. Okay. But you know, it is not supposed to come in a day or two. It's a work in progress.
Over time. Okay, so let's look at service delivery. Yes. I'm asking you this question because we've received complaints about quality of services of even the HMOs, especially this coding of a thing. It could be frustrating for enrollees sometimes. Why are we having such bottlenecks, and what should enrollees be doing in the event that they feel shortchanged or something, or being treated shabbily?
Okay, I think one milestone problem of the National Health Insurance Scheme, there were no existing structures to receive those complaints, to process those complaints, and to be able to address the complaints. Okay. And these are some of the strategies that we are putting in place. For example, the enrollees will be going to the healthcare facilities to receive services, and there are defined services that is supposed to be covered by the National Health Insurance Scheme. There are defined range of drugs that are supposed to be covered. In our last interview, those information were not there. NHIS is developing list of essential drugs and services, and those services will be uploaded into our websites, and we will develop pamphlets to ensure that we disseminate them so that every enrollee that is under the National Health Insurance Scheme will study it, will know his right, will know his obligation, and it can even, because it is in our website, you can have it in your own handset, so that if you go to a healthcare facility and drug is prescribed to you, and you are not able to get that drug, or somebody tells you that that drug is not part of the package, you just browse it and you see, and you show them that, look, this drug is part of it. So that we have done. Now, how do we ensure that complaints are received and complaints are processed? And this is what we are working on. Part of our overarching digital transformation, there is what is called this call management center, whereby from wherever you are, if you have a complaint, you can call our toll-free number, and that call will get you linked to the MCC. That's our management center at Wuse, and from that it will be routed to the state where the call is emanating. So what we have developed now, we have sensitized all the healthcare providers because we want to be more responsive in getting that in ensuring that our enrollees will not be receiving complaints. We have developed a very small, simple system. In every state, we have employed healthcare professionals because I told you it's a structural issue. If there are no healthcare professionals in our state to be in the vanguard of looking at those complaints, there is no way we can resolve those complaints. And I told you that first and foremost, we need to have appropriate human resource who can be able to receive complaints and process those complaints. We have also tried to ensure that HMOs that were owing money from healthcare facilities have defrayed it. We have gone far in ensuring that we have retrieved those monies, and we have put in a credible mechanism that will ensure that every quarter a reconciliation exercise is done so that healthcare facilities will not be complaining that HMOs are owing them and therefore they don't have resources to do that. That we have put a mechanism. And the next mechanism is we are now focusing at the healthcare facility level. We have developed a simple structure before even we begin to use this call management system. Every enrollee who goes to a healthcare facilities, he has a complaint to make, either because of something is denied or something wrong is done to him. The numbers of our healthcare providers in our offices will be displayed in each and every facilities.
Oh, that's good.
So that if you have a complaint, you call that number. If the first one is engaged, you call the second number. And that healthcare facility has a comprehensive complaint record, who will now record, I am Mr. Sambo calling from a particular facility in Katsina State. It will be recorded. What is the nature of the complaint? What is your NHIS ID number? Then it will be taken. Each facility will give us who is a desk officer. In case there is any complaint, we now route the complaint to that desk officer, and we now ensure that that complaint is received. And if we call a particular facility and we cannot get the desk officer to attend to the complaint, it's an offense under the new rule of the National Health Insurance Scheme. So we will now aggregate all the complaints that are emanating from healthcare facilities. There we are trying to define what is a tolerable limit of complaint that we can take. Beyond that tolerable limit, we will give a healthcare facility a warning. If by next month we aggregate complaints from the same facility and we discover that they have reached that critical level, we give that a facility a warning. That's a yellow card. Then if it happens again, we will give that facility a red card. From there, we will now say, okay, this facility cannot be able to
lead to the listing. The listing,
or we now move to our enrollees to the next responsible facilities. So I think the introduction of this mechanism will be the game changer in terms of complaints, incessant complaints that our enrollees are receiving.
How soon will that become a reality?
You see, we have developed the strategy, and we have brought in the healthcare providers. We had a conference with them. We have informed them. The next leg is that we are going to even have a larger meeting with committees of chief medical directors so that they understand the new structure we put in. Once we put in this, because you cannot start penalizing people on something, on a structure that you have developed and you have not educated them and you have not given them time to put the necessary structure in place. So this is what we are doing. As I told you, it's a structural issue. We did not meet credible structure that will respond to the so that's why we are all developing gray hair. If I look at all our general managers because of the enormity of work that we are doing that's supposed to have been done 20 years ago and it has not been done. So but we are trying just exercise a little patience. You will see how NHIS will be transformed in few months to come by the grace of God.
I'm sure the viewers are really glad to hear you working at such a thing that will make fast track coverage. I know that some tertiary health care are covered, cancer care, renal treatment and all of that. And the scope of coverage is what I'm interested in now, because a whole lot of people or patients out there are still groaning. There are so many things not covered. What do we have to do to make things easier for anybody who comes down with such ailments when it comes to treatment?
Yes.
And they are covered by insurance.
What you accumulate in the health insurance fund is what you will use to purchase care. If you accumulate huge fund, it will enable you to purchase huge benefit package. If you accumulate little resources, and these resources is obtained from the salary of workers and nothing more, you will be able to purchase what you have been able to accumulate. And this thing is not done by just imagination, but by scientific actuarial determination. That will now define what a health insurance agency can be able to purchase. Beyond that, it cannot purchase the healthcare more than what it can purchase. I mean, there must be a benefit package, and there must be a fund to purchase it. But because of the desire of the National Health Insurance Scheme, despite the fund constraint, to be able to cover those chronic diseases like cancer. That's why we are going into innovative financing, because health insurance anywhere is a science. It has to be dynamic. You cannot say, okay, because the money that you are accumulating is so small, you cannot use your brain to think out of the box to create. That's why we develop what we call NHI, a new initiative that we call NHIS drug system. We copied what has happened during PTF, whereby manufacturers of drugs are branding drugs in the name of PTF. And wherever we reach a situation in Nigeria, wherever you go, you see drugs, you see medical equipment with PTF inscription under the chairmanship of our president. So we borrowed that leap, and we brought in drug manufacturers in Nigeria, and brought all the stakeholders that are working in the drugs, the custom, the Ministry of Industry. We held a series of rigorous meetings where we came up with that strategy. And I'm glad that the Honorable Minister has approved that. What is the length and breadth of that initiative? We will now have a situation whereby we use the Manufacturers Association to develop drugs that are branded with NHIS inscription. That will bring about, that will bring down the cost of the drug. And that will also bring availability of drugs. So for cancer, we have already got we have already signed memorandum of understanding. Yes, with Roche. Roche has agreed to bring the new drugs for treatment of cancer, and they will subsidize it by 50%.
Wow, that's interesting. So
NHS will only pay 30%. Then the patient will pay only 20%. Wow, this is one of the greatest innovations that we have done in the healthcare delivery system.
It's indeed a welcome development, Professor Sambo, and we look forward to the actualization of that. Thank you so much for coming on.
And I'm happy to tell you, NAFDAC has even approved that branding of cancer drugs to manufacture to Roche.
Okay, so it's really great news for us. Thank you so much.
Thank you.
package for this week. A quick reminder that you can go to our YouTube channel to watch the upload of these and other episodes of the program. Email us for your comments and contributions at healthoptions@nta.gov.ng. My name is Rabi Abdullah. Keep staying safe. Hope to see you again.